Rajneesh, welcome.
Yeah,
Welcome to
thank you. Thank
Hyderabad.
you, Dr. Kahali.
Yeah, Iman here.
2.7.
So,
Yeah. Oh, yeah, oh, yeah.
what is your
And
case? Please tell us.
Yeah. So first of all, it's a profound privilege doing a live case at a national conference. And good morning, Dr. Pratap.
Yeah,
Sorry, I
Pratap
couldn't
is
make it
also with
yesterday.
us. Yeah.
Yeah. So it's a absolutely honor and privilege. And thank you, Dr. Pratap and Dr. Kasturi, for giving us the opportunity to present this live case in this national conference. And as usual, it's an elite panel. So again, a honor and happy Doctor's Day to all of you.
Same to you and your team.
same to you.
Yeah, so we are presenting this case from Medanta with me, Dr. Himanshu, Dr. Shashi, Dr. Ashish. So we have a elite interventional cardiologist team here and all imaging guys and all nursing staff, technicians. So we are all set to present this case and we start from the beginning. So can we have that patient's history? Patient's history slides. Okay, no, is it being shown there? Please show the patient's history slides.
Yeah, we can see.
Yeah, we can
Okay.
see.
Okay, so this is a 67-year-old male patient. He's hypertensive. He had a coronary artery disease. He had prior procedure in 2020. The details were not fully available to us, but this time he landed with unstable angina and ECG changes. Angio was done outside, but I didn't have that videos prior. So we admitted the patient and the angio I'm going to show. And previous stents, it was mentioned that he had one stent in RCA, but to our surprise, it was different once we did our angio. So this is the first shot. So it's very clear that he has a distal left main disease, which is significant.
We are unable to see the angio.
Okay, can you show the videos? I think this AV guy has to coordinate. Okay. So
Yeah,
is
now
it?
we can see.
Yeah,
Now
yeah,
we can see.
yeah. So the left-sided angiogram and distal left vein very significant, extending into the ostium of LAD, and the circ ostium is again very critical. Show the next view. Yeah. So there is some disease in the LAD beyond diagonal also. So this is the pictures, and as I mentioned, history was not clear, but we thought that there is a stent at the left main distal crossover, left main to LAD, done two years back. Then we thought we'll do the imaging and confirm this. So RCA is fine. We can show you the right coronary angiogram. This is absolutely fine. The stent was there, but that's patent. So the culprit lesions are this left main, circ ostium, and it's a complex bifurcation. Okay, next. Okay, hold on here. Hold on. So then we started this. We have been waiting for almost half an hour. We started the procedure and did the IVUS first. So one thing I just want to mention that first time we're using this new IVUS hardware, which is a Assist HD IVUS. So this is first time in India. We have been using Philips as well as Boston prior. So this Translumina has brought to India Assist HD IVUS. We are showing you the image through that. The difference,
Very nice image. Yeah.
yeah, we'll show. I'll just like to mention the differences of this IVUS hardware versus the previous IVUS machines. So now this is working with the same catheter. We can have two frequencies. We can just switch to the frequencies with the same catheter, while this was not available with the previous IVUS hardwares. There's a 40 megahertz and a 60 megahertz. Just by a button, we can switch it to the different frequencies. So high resolution and peripheral or coronaries, it can be used. And then also the maximum speed of the pullback is there with this IVUS. So this is, we have done the IVUS with this machine. Can you just run the IVUS? No, first run the IVUS. First run the normal IVUS. Yeah, run it. So this is from the distal LAD, we're coming back. So this is distal to the diagonal, and then comes a point around the diagonal where again there is a significant lesion in LAD. So this is that one.
Yeah,
Yeah.
very nicely depicted.
Yeah. So this is that diagonal around diagonal the LED lesion. Keep running, don't stop. There's quite a big atheroma volume. There is some calcification. We're coming back. So now LED is better here, but now we are entering the left main. This is the stent. This is the previous stent.
Yeah.
So this is the left main lesion, very critical.
Which is like it is unexpanded, like it is expanded less.
Yes, yes. So at one point it is not, it's under expanded stent. So probably that is the reason he had a ISR. And then we calculated, we were interested in knowing the caliber of the vessel with the LED where we are planning to park the stent distally as well as into the left main. So distal LED was almost 3.5, show that. Okay, so this is that distal LED size where we are planning to park our stent distally and then come to the left main. Left main is 4.3, 4.4. So this is the imaging prior. I think we can have a discussion and will be absolutely, the inputs from the panelists and chairpersons would be really welcome. And then we can discuss what strategy we are planning. We have done few steps already because we are waiting for 25 minutes. So please, inputs from you.
What are your plan for this particular, disease? You have got a very severe narrowing of L6 and takeoff is quite sharp there. And then there is also a lesion which is seen in the distal part of LMC before bifurcates. So what is your strategy now?
Yeah. So if you ask our strategy, we planned it as a DK crush only. So we measured the lengths of both the lesions, caliber, and then planning a DK crush with a stent first into the circumflex, which is acting as a side branch here.
Yeah.
We'll crush the stent of the circumflex ostium. We have done up till this far, and then the first case, and then a full crossover stent from left main to the LED, which is around 38. We have measured the length on OCT as well as IVUS. We have done a OCT also. Would you like to see a OCT? Yeah, we have done both.
Please.
Yeah, run the OCT. So this is the OCT image. Yeah. So this is ISR, and this is left main. So this is our strategy, but I think we can. It's worthy of a discussion that if any different opinions are there. Yes.
What did you do for the ostial circumflex? How did you modify? Just simple
Yeah,
ballooning or?
No.
Use
So
cutting balloon or
let me show you. If you allow us, I'll show you the steps we have done. Next, please. Next. So wired both. Next. So first, obviously, this is the imaging, OCT as well as IVUS. Next. Okay. So first we have dilated the circ ostium as well as the instant with a 2.5 millimeter balloon at high pressures, and then took a cutting balloon. So this is 2.5 into 15 cutting balloon at the circ ostium. We went at almost 15 atmospheres, slowly, gradually. Next. So this is a Wolverine cutting balloon from Boston. And this is after the cutting balloon, how it looks. So we have modified the circ ostial lesion with a cutting balloon. Next. Okay, so this is after.
Good, Rajneesh.
Yeah. So then we have also done the next step. Next. Okay. So now we are at a step where we are placing a stent at the circumflex ostium. This is Zines 2.75 into 13. Next, with a small protrusion into that left main. Next. Yeah. So this is the placement position. And already see, you can decipher that there is a 3.5 balloon into the LED. to crush this stent. And that is also very important and crucial that the sizing of the balloon with which we crush should be absolutely adequate and to the vessel of the, almost to the size of the parent vessel. Okay, so this is high pressure 2.75 13 Zymes at circ ostium. Having done that, next.
Did you do the imaging first of the circumflex?
No, we haven't done this circumflex. Patient was having angina after the wire, was complaining of lot of chest pain. So we didn't do the specific imaging of the circumflex. So this is the crushing part first. Okay, next. Yeah, we crushed it to 3.5 almost at 20-22 atmospheres. And then rewired. So rewiring is again a crucial step from a proximal cell. And then this is first case. We have done up till this point. This is a first case with 3.5 and 2.5 balloon, 3.5 into the left main LED and 2.5 into the circ ostium. Next. Next. So this is after the first case.
Yeah, looks to be very good.
So we have reached this far. So now next steps. I think let's take the stent. So any inputs, please give us your
It's very
thoughts
important.
about this.
Yeah, the crossing becomes very important in the type of technique what you're using. If it is a decay crush, it's always that recommended that you go from the proximal strut rather than distal strut, because distal stress means again you are going to distort the stent. Unlike what we do in the other kind of techniques where T-stenting, tap stenting are good, we would like to go more distal or middle part of the struts. So this is an important thing what you have shown, that you have done from the proximal struts, the crossing. And most important is that, as you said, that after this kissing, usually we do a pot also in the proximal, so that we don't again have a mismatch of this proximal part of the stent.
So are you
No.
going to do some pot now?
No, we haven't stented the main vessel. It's only side vessel up till now.
No, but
So we-
there are 3 pots in decay crush. So first one is after the first case.
Yeah, we can do that, but at the moment, so with that kissing first case, it was aggressive dilatation in left main as well as the circ ostium.
To
We
facilitate the side branch ostium pot.
Yeah, so we have been thinking to further upgrade 2.4. We have done the circ ostium 2.5. So we are planning to do it with 2.75 because vessel looks around 2.75 to 3, the circ.
Yeah, actually the circumflex is much bigger than 2.75 actually.
Yeah, so we are taking the. Huh?
What is the
Alright.
IVAS finding of the measurement of circ? Oh, you didn't do it actually. Oh, okay.
No, IVAS circ we haven't done it, but now we can do it. Actually, now the patient is absolutely comfortable after opening of these. But let me do the 2.75 and 3.5 kissing, which is kind of more adequate first case, and then we can show you the IVAS of the circ. So we are just going ahead with 2.75 into the circ ostium and 3.5 into the left main LED. छोड़ना वायर छोड़ना okay 3.5 3.5 balloon this was n by 2.75
2.75 YouTube नहीं वो पहले यूज किया हुआ
Yeah. So Rajneesh, if you permit, we are going to the other lab and let us see how Anand is positioned. And within
that's
5
fine
minutes,
that's fine
Rajneesh,
That's
within
fine.
5 minutes, we'll be coming back to you. So you
sure Dr. Kali look forward yeah
Rajneesh,
so
we are back
yeah.
to you. Yeah.
Yeah, Demon. So we have done the kissing with the higher balloon, 2.75 at the circ costume and 3.5. So please show that. Come back. Come back, come back, come back, come back, come back. Keep coming back. Come back. Come back.
और कर और पहले और
Come
पहले और
back.
पहले और पहले और पहले और
Come back.
पहले किसी को करे और पहले
Yeah. So this is 2.75 and 3.5 at good pressures. And then as you are requesting or as you are wanting, we have done the IVUS image of the Sir costume also. Can you run that? As the time is short, I'll just continue with my steps, but please run that IVUS image. This one.
हाँ ठीक है
Yeah.
बिल्कुल सही है
8, 10, 12, 14.
1 मिलीमीटर रेंज
Down.
1 मिलीमीटर रेंज चला गया
हाँ कोई नहीं वायर दो. Okay, so this is the IVUS. Stent looks well opposed.
Yeah.
Vessel looks 3. And now after this, I have done the 3.5 into 38 crossover stent from left main to the LED, covering the distal LED, I mean mid LED lesion also. So please show that.
What stent you are going to give this one, Rajneesh?
So Zines again, both are
Okay,
Zines.
okay,
Both
okay,
are Zines, and this is 3.5 38 from left main to LED. This one, yeah, please show. Okay. So yeah, so this is the placement. Next. And then we have post dilated with 3.5 into the LED and did a pot with 4O balloon into the left main. So after having done the pot with 4O almost at 16, 17 atmospheres, I am going to rewire again for the second case. So this is a rewiring after the pot has been done.
Just now we had a nice lecture from young Gino
Yeah.
regarding the virtues of pot.
Check.
So we are all
I was
now
hearing
about
to
pot.
that. It was really wonderful, and no doubt that pot.
Yeah, the results look to be very good, Rajneesh.
Yeah.
It looks to be nice. Yeah,
Okay.
where is his
So this
stuff?
is the
But
cross, and
yeah,
we
he
were again
probably
careful.
has gone through the
Check,
distal one. Yeah, he went up and distally and then came back.
Yeah. So I'll try to rewire
Yeah,
from the
yeah.
proximal cell again.
Do you use stent boost here to facilitate your entry?
Yes. We do that.
How is your corroboration between the IVUS stent boost
I
and the
think
IVUS?
this is a more proximal cell, and what Demon was wanting exactly that we should go from more proximal. We have gone through that, and let's have a kissing balloons once more. 2.75 taken, and maybe 4 this time. 4 is here already. Okay, so we are ready for the second case and then pot after that, and if time allows, we'll show you the imaging.
Dr. Rajneesh, what was the pot balloon size did you use?
4O balloon
4O,
at
yeah,
18
he
atmospheres.
But
So
according to the
we
IVUS, you are telling it was 4.5, the left.
4.3. It was 4.3. So we have almost reached that point with the inflation of this pot balloon. It was 4.3.
Yeah, so he has gone up to 15, 16, so he must have reached 4.3.
18 atmospheres, yes.
18, okay.
Yeah.
And circumflex ostium, you're going to, you have taken
2.75 initially separately at 20 atmospheres and then a kissing both at 15 atmospheres.
So this is what balloon in the circle.
This is again 2.75.
2.75. You haven't any plan to do with 3?
We can actually think after this if it is looking under or this thing. So I want to go with high pressures of 2.75 and then see. So first, okay, 2.75 go high, go up, 15, 18, 20. So this is the cine of this down.
Yeah,
I
has
think
dilated very well.
yeah, it looks good.
Looks
And
good,
now
very good.
I'll do the kiss. Okay, 12 both.
So what's the balloon in the LED?
12
3.5 or
down
4?
both. No, now this time it is 4.
4, yeah.
So
Yeah.
don't you
So we
use
have done
this?
the, yeah.
I just want to ask you, see, when we are trying to do this kissing, would you like to do the size of the balloon equivalent to circ and also the size of the an LED as distal size of the LED? Would like to do that way because we need to do, two-thirds of the summation of this.
Finet's law. He is mentioning about Finet's law, yeah.
Okay, go up again. 12 both.
Because always size according to distal
Down
size
both.
of the LED and
Looks
then
to be very good, Rajneesh.
Yeah, yeah.
Yeah, very
So,
good.
so this is, we'll give you a picture, angiographic picture now and,
Hopefully
okay,
it will be a nice one. Yeah.
okay. Yeah, hold on.
Looks to
Hold
be
on.
nice now. The
I'll show
sarcostia
you
is
again
nice, yeah.
and, yeah. So,
Okay, those are good.
okay. So this is how it looks. And I'm going to do the pot again and then if time allows, I'll show you the image. Okay, give me a stand boost for the pot. Listen to the patient. Patient is saying something. Okay, go up.
Hold on.
10, 12, 16, 18, 19
So
down.
this is very important what Rajneesh is showing, that we should have the balloon, pot balloon before the carina. We should finish before that. That's very important.
Okay, give me that IVUS catheter. First LED and then if time allows, we'll show the circ also.
Yeah, we have 8 minutes left.
Yeah.
And
So I
in
think,
between, Rajneesh, you have to permit us to go to Anand to see his final result. You
please
show me
go
some.
and then I'll show you the images, both.
Okay. So
Here
Rajneesh,
and
yeah.
yeah, I'm showing you the IVUS image from LED to left main.
Yeah.
Please run that. So we have done both. We are complementing IVUS OCT specifically for this, although routinely we are using one imaging modality, but we have taken OCT image also. First run the IVUS, it is from the same Assist HD machine.
Yeah, it's
And it
very
looks
good. I
good.
was just going to comment that it's very nice.
Yeah,
Very
resolution is
nice
good.
picture. Excellent.
And some additional advantages over the previous ones. Translumina is expanding. Okay. Yeah. So
Yeah,
this is the left main now.
apposition
Looks
is good.
And OCT image also. Can you run that? OCT image on the main screen.
Yeah, apposition is good here also.
Now take this. Run the OCT. Yeah.
Yeah,
IVUS में है ना? Run
Run.
IVUS.
it's distally. So Rajneesh is showing both together, IVUS and OCT. Yeah,
The position is better seen
Yeah, better.
with OCT. So that will be
Yeah.
advantage of OCT.
Yeah.
Smaller position
So-
is very well
resolution
seen.
is better in OCT.
OCT, yes.
But you see, the IVUS 60 is also equally good.
Yeah,
You
that's
can
true, but
see the
even
apposition
minute
very well.
amount of,
Yeah. Okay,
apposition,
sure. Yeah,
malapposition
OCT
we
is
can
little
see with
better.
this.
Yeah,
I think both have their advantages, pros and
You
cons.
are,
So
Rajneesh is showing
lesions,
both together. Yeah.
if contrast,
Great, Rajneesh.
if there's a kidney dysfunction, the
Yeah.
final image is
Within
a
a short time, you have managed to do everything. Great.
circumflex image also. I'm showing the IVUS. This is the last image. Please run that. So
Yeah.
this is IVUS from circumflex
Yeah,
coming
IVUS,
back.
Looks to
Well
be good.
approached, and this is left main.
Yeah, very good. Yeah.
So final angiographic view I'm showing, and this is the final picture. Come caudal, please. More caudal. Okay. Yeah.
Excellent.
Yeah. And epicranial last shot. Then we remove the wires. Yeah. So there is some pinching of the diagonal. It's a big
Yeah, I
branch,
was
but
noticing, but it may be FF1 negative.
yeah. So no changes.
It's
Patient is
borderline
fine.
70-80%, so maybe FF1 negative.
Timmy flow is quite
Absolutely.
good in that.
Yeah,
and that's-
Timmy flow is very good.
Absolutely.
Diagonal is
Absolutely.
also not a small artery, it's a big branch, 2.5 almost.
Yeah,
big
so
branch.
this is,
But I think the TIMI3 flow is very good and it's better to keep it like that instead of deforming the LED stand, isn't it?
absolutely agreed.
In fact,
Yeah.
the study which is published in JCC which shows that even if there's pinching is there, when the TIMI3 flow is there, majority of the times, 90% of the times, FFR is negative in them.
Yeah, absolutely. And Dr.
Absolutely.
Colombo was here just now, and Dr. Colombo and Ajim Latif has several papers who have shown that if it is 70%.
There is a
Yeah,
EBC study
yeah,
recently
yeah,
which shows that even if it is showing a relatively significant but TIMI flow is good, no changes, it's better to be provisional.
yeah, yeah. Absolutely, absolutely.
Yeah.
Yeah,
So
so give a
this is
big
it.
hand to Rajneesh and his team. Great job done, Rajneesh. You have shown
Thank you,
everything.
Dhiman,
OCT, IVAS, such a fantastic job you have seen, shown
and
us within
thanks once
50
again to
minutes.
Dr. Pratap and Dr. Kasturi and
We really enjoyed Rajneesh. It's a fantastic job on your part. So please give a very big hands to Rajneesh. We want a very big hand. Yeah.
thank you,
So
thank
Rajneesh,
you.
thank you
Rajneesh.
very much. And if you permit, we are going back to Anand again.
Yeah,
Please,
sure,
just
sure.
to show. Thank you very much and see you over here. Thank you.
Thank you, thank you.